change the facial proportion and make the beauty by orthognathic surgery, by interval approach, there is no external scar. So, while the jaws are not aligned properly, there are lots of problems. Problem in appearance, problem in chewing, problem in speech and breathing also. So, these are the candidates for the orthognathic surgery where the maxilla is anterior-posteriorly deficient or excess, maxillary vertical deficiency or excess, and mandibular anterior-posterior deficiency or excess, or mandibular asymmetry or facial asymmetry, or mid-face hypoplasia due to cleft lip and palate. We know in case of cleft lip and palate, maxillary is hypoplastic maxilla. And there are some syndromes like Apert syndrome, Crouzon syndrome, golden hair, Romberg, peri-Robin, and Pioneer syndrome, and sleep apnea for the short, due to the short jaw. These are the main candidates for the orthognathic surgery. And before going to orthognathic surgery, we have to plan who is the candidate and how we will assess the patient. Either we go for the orthognathic surgery or the orthodontics. So we do the general analysis. And basically, main is the aesthetic unit, aesthetic evaluation. It is done two ways, frontal analysis and the lateral profile analysis. In frontal analysis, when we do the analysis, the patient should be examined in a natural head posture, and the teeth in centric occlusion and the lips are relaxed. All muscles of facial expression, all should be relaxed. And natural head posture is the posture in which the patient is oriented his or her head and which feels most natural. That is the natural head posture, and we should examine in this way. And in frontal analysis, we should see the front facial form, transverse dimension, facial asymmetry, the vertical relationship, etc., etc. In facial form, the height and width of the faces, in case of female, the height and width proportion is 1:3 is to 1.3 is to 1, and in case of male it is 1.35 is to 1. And the bigonial weight is always 30% less than the bizygomatic weight. But when the bigonial weight is a little bit closer to the bizygomatic weight, the face is always looks, in case of male, the face is always looks manly face, square-shaped face. And when we draw the vertical lines in the inner canthus and the outer canthus, it will divide the face into equal 5%. This is the transverse dimension. And obviously we should look for the facial symmetry. Here we can see that the center of the forehead and the nasion and the center of the upper lip, lower lip, center of the cheeks are in a straight line. But in case of facial asymmetry, all are away from the single line. And in case of facial asymmetry, we should analyze this case by anterior-posterior saphometry rather than the lateral saphometry. In anterior-posterior saphometry, we can judge the defect. And the face can be divided into three parts, we know: the upper third, middle third, and the lower third. Upper third is the hairline or trachea to the glabellar area, and the middle third is the glabellar to the subnasally, and the lower third is the subnasally to the menton. All are equal in soft tissue analysis. And the middle to lower third vertical heights of the face should have 5:6 ratio, and the upper lip length should make up 1/3 of the lower third facial height, and sternum inferiors to the soft tissue menton should be equal to 2/3 of the lower facial height. And normal upper lip is always 22 mm plus minus for female and 22 mm plus minus 2 for male. And the lower lip is 40 mm plus minus 2 for female, and for male it is 44 mm plus minus 2 mm. And with the patient lips in repose, the amount of maxillary incisor to the exposure beneath the upper lip should be noted. And chin is also evaluated for symmetry, vertical relation, and shape. And the cant of the occlusal plane is evaluated especially in individuals with facial asymmetry by asking the patient to bite on a wooden stick and then relating the occlusal plane to the interpupillar region. Here we can see the painting in facial asymmetry case. And the amount of gingiva exposed during smiling is always noted, because the ideal tooth exposure with the smile is full tooth, then 2 mm of gingiva is accepted, but if it is more than that, which indicates the maxillary vertical axis, which should overlap. And the surgical superior repositioning of the maxilla is indicated only when the excessive gingival exposure is found in combination with the interlabial gap, maxillary incisor exposure, and the vertical height of the lower third of the face. And the amount of surgical superior repositioning will be dictated by the amount of the tooth exposure, lip length, crown length, and the gender. So during analysis of the lips, lip symmetry should be evaluated. We know the lower lip generally exhibits 25% more vermilion than the upper lip, and the lips should be 0 to 3 mm apart in repose. But keep in mind, there are specific racial differences in lip thickness. And in lateral profile analysis, we can go the upper third of the face. The supraorbital ring normally projects 5 to 10 mm beyond the most anterior projection of the globe of the eye. And in frontal analysis, we see the frontal bossing, supraorbital hypoplasia, exophthalmos, enophthalmos, and the globe generally projects 0 to 2 mm ahead of the infraorbital rings, while the lateral orbital rings lies 8 to 12 mm behind the most anterior projection of the globes. And always we observe the paranasal areas, as because it indicates the middle third deficiency and mandibular anterior axis. And the ratio of the distance from the nasal tip to subnasally and from the subnasally to the alar base creases is normally 2:1. So patient with a class 3 malocclusion and decreased nasal projection with a short nose should always be treated by mandibular setback rather than maxillary advancement. And so, in lower face, we can evaluate the lips, labiamental fold, nasolabial angle, chins or area. And again, the upper lip is usually projects slightly anterior to the lower lip. The upper lip should be 3 plus minus 1 mm ahead, and lower lip 2 plus minus 1 mm ahead of the lower facial plane, which is drawn from the subnasally to the pogonium. This is the lower facial plane. And the lips position related to the underlying dental position, maxillary dental protrusion and lack of lip support in case of class 2 division 1, and excessive orthodontic retraction will hamper the lip position. And anterior posterior lip position assessed with the help of the E-line, which is drawn from the tip of the nose to the pogonium, the S-line, which is the mid portion of the nose to the pogonium and the lower facial plane. And labiamental fold will be 130 degree, and this angle is often acute in cases of class 2 mandibular and epideficiency. And this angle is flattened again with microgenia or lower lip tension caused by the class 3 malocclusion. So it is measured, nasolabial angle is measured between the inclination of the columella and the upper lip, and it should be 85 to 105 degree. The larger angle is acceptable in female, and smaller angle is pleasant in female. That is nasolabial angle. So surgical or orthodontic correction of maxillary incisors should be avoided in individuals with large nasolabial angles. And where crowding necessitates the tooth extraction, whether I will extract the first premolar or second premolar for orthodontic treatment, it will be dictated by the nasolabial angle. And so surgical repositioning of maxilla, in general, the maxilla should never be moved posteriorly, especially in combination with superior repositioning. This surgical movement will lead to loss of lip support, increase the nasolabial angle, increase the nasal projection, and flattening of the alar base, ultimately poor aesthetic and premature aging effect. So the maxilla should be more posteriorly only in individual with true maxillary protrusion, otherwise not. And in chin, we should evaluate all three dimensions by the chin, the ligamental fold, chin shape, relation to the dental midline, symmetry, cant to the lower border. Basically, cant is evaluated for the facial symmetry. And the width of the chin should be assessed in relation to the overall facial shape. And the narrow chin is often knobby appearance, and the surgical advancement of this chin line widening of the chin should be contemplated in cases of narrow chin. When we advance the narrow chin, then also we should, as well as widening should happen. So consider the zenioplast not only the anterior posterior position of the bone, but also the chin shape and the ligamental fold. And the chin throat angle is the presence of a double chin and adipose tissue should be noted in the name. And normally chin throat angle normally 110 degree, which provides a better and better chin definition. And the distance from the neck throat angle to the soft tissue bone should be approximately 42 mm. So these are the essential unit for the analysis for aesthetic unit analysis. And now we come to the radiographic analysis. In radiography, we use the panoramic X-ray, that is orthopentamogram. Then cephalometry, we know the cephalometry is two types. One is the lateral cephalometry and another is the anterior-posterior cephalometry. Basically, in case of facial asymmetry, we use the anterior-posterior cephalometry. And intraoral periapical view are sometimes necessary to see the crowding and root position, these and that. And then after analysis of the radiological analysis, we go for the model analysis. In model, we see the compatibility of the jaw, then the inter-arch relationship, any crowding, any movement need for orthodontically, this will judge in the model. And after model analysis, we go for the virtual treatment objective, that is video. Video is prepared firstly from the lateral cephalometry, then we go for our planned operation. In this case, our plan is to advance the mandible and also the chin. So there is a marking here. There is a marking for chin and for BSSO, and our plan for maxilla is maxillary anterior portion a little bit rotated and posterior portion will advance. So my predicted result will be like this. Then we go for the surgery. And before going surgery, there are some sequential treatment plan. Then first of all, the dental and periodontal treatment. If needed any extraction, we know in case of bilateral sagittal split osteotomy, while we plan is for setback, we need to extract the third molar. So before operation, we have to extract the third molar 6 to 9 months before operation. Then go for the pre-surgical orthodontics. Pre-surgical orthodontics is that we know the face already compensated, by the tooth is already compensated. So in case of class 3 malocclusion, lower anterior teeth is retroclined due to lip pressure, and upper anterior teeth is proclined due to tongue thrush. So orthodontic role is for the decompensation. And then after proper adjustment, then we go for the surgery. And after surgery, there is a post-surgical orthodontics, which will be about 3 to 6 months. And then for a retainer for a few months. Here some ideas taken from the internet, not me. We can take some idea how the zenoplasty is done. Here look at the shape of the chin, and after advancement, shape is good, and it is fixed by the mini plate fixation. And here it's a class 3 malocclusion, mandible is orthognathic, and after orthodontic treatment, then mandible is set back by bilateral sagittal split osteotomy, then total facial profile will improve. This is another case. In case of class 3 malocclusion, sometimes we need to bimaxillary surgery, sometimes we need to advance the maxilla, sometimes we need to both. Mandible should set back or maxilla advancement by reformostomy. And here is the case showing here the maxillary vertical axis where the gum is mined and is corrected by orthognathic surgery by reformostomy and superior repositioning of the maxilla. So these are the basic procedure. And now I'm showing some cases. It's a case of golden syndrome, that is hemifacial microsomia, short chin, and here tag here. And this is the lateral supplementary. And after alignment, then after alignment from this lateral supplementary, we prepare the tracing, and from this tracing we do the videos. Again, here then is maxilla rotation, setback, and posterior part advancement, and chin, and zenioplasty for advancement, and gaze for advancement. And this is the immediate result. And this is after 2 years. It's a pleasant result. This is also after 2 years in the lateral profile. And most important factor is, as I mentioned in my talk, is the aesthetic and functional outcome. So let's see what is the functional outcome. Here she was a patient of sleep apnea. Her posterior airway space is only 7 millimeters. But after maxillomandibular advancement, her posterior airway space is now 18 millimeters. So now totally she is free of sleep apnea. And again, these patients have a short mandible or short chin. It also treated by maxillomandibular advancement. I have done maxillary advancement, mandibular advancement by bilateral sagittal split osteotomy, then advancement zenioplasty to pull the genioglossus. And then the result, it was again 7 millimeters, and after operation it was 17 millimeters. This measurement was done postoperative lateral supplementary. It's a case of facial asymmetry. We can see the canting both in the occlusal cant, both in the chin canting. And this is the model work and how to prepare the patient for surgery. Here maxillomandibular rotation was done. There is a counterclockwise rotation was done. In upper jaw, we have done the Leaford 1 osteotomy, and in lower jaw, bilateral sagittal split osteotomy, and also in the chin, we have done the propylaptide zenioplasty. So that is the result. And her, again, right side of the face needs some lipo filler. It's another case of maxillary severe elongation or vertical maxillary axis. In the lateral supplementary, you can see the vertical maxillary axis. So Leaford 1 osteotomy and segmental osteotomy in the mandible also done for this case. It's a case of cluster division 1 malocclusion with high maxillary vertical axis, and Leaford 1 osteotomy was done after orthodontic treatment. This is a case also a vertical maxillary axis as well as the cluster division 1 malocclusion with short upper lip. It was after orthodontic treatment, total maxilla is superiorly repositioned by Leaford 1 osteotomy. It's a very interesting case. After orthodontic treatment, when she is in normal position, her lips is like this and her upper tooth shows, which is more than normal. And during smiling, her upper jaw is, upper gum is totally exposed, which looks ugly. And so for this reason, she seeks treatment, the orthognathic surgery, and I have done the superior repositioning of the maxilla and a little bit advancements in zenioplasty to make her chin sharp. And that is the result after operation. Here is the smile line now and her total facial profile. Here's the normal position. Now her incisor shows about 2 millimeters. we know 1 to 4 millimeter incisor is acceptable. And that is the lateral profile during orthodontic treatment, after orthodontic treatment, and after surgery. It's another case of bimaxillary proclination, short chin, but lip length is quite normal. So I have done orthodontically proclination of the upper and lower jaw, and before one osteotomy for repositioning of the upper jaw, and advancements in your plastic to make better profile. You can see the lateral profile. Here is the E line. It's more or less normal. It's a fantastic appearance. And this is the bite after operation. It's a case of maxillary hypoplasia and and class 3 malocclusion. We have done leaf 1 osteotomy and advancement of the maxilla, and this is the result. It's another case of class 3 malocclusion. I have done leaf 1 osteotomy and advancement of the maxilla to make this contour. And this is after bite after operation, class 1 bite. It's another case of maxillary vertical access. It's also a case of maxillary hypoplasia and advancement of the maxilla by leaf 1. It's another case of class 3 malocclusion with mandibular, class 3 malocclusion with open bite, and my plan is both jaw surgery, leaf 1 for maxilla advancement and BSSO for setback, and this is the result after operation. This is 1 month result after operation. It was done 1 month back. And this girl comes from Estonia in Bangladesh. Her main problem is she cannot smile. During smiling, her anterior teeth not exposed, so she doesn't like her smile. It's a class 3 malocclusion, and my plan is for advancement of the maxilla and by leaf 1, and as well as a little bit zenioplasty to make the contour very good. Lateral supplementary, and from this lateral supplementary we do the stressing. From this stressing of the video, and in video you can see that leaf 1 advancement as well as slight zenioplasty. So, and this is her result, this bite in class 1 bite and after result. And it's a case of severe mandibular prognathism and class 3 malocclusion. Our plan is mandibular maxilla advancement by leaf 1 and mandibular setback by bilateral sagittal split osteotomy. And this is the result after operation. You can see the facial contour angle. We know in case of male, facial contour angle, which is drawn from the clavilla to the nasion and from the nasion to the pogonion. It's about, in case of male, minus 11 degree. So it's near to the normal. And this is the dental bite. This bite was before operation like this, which in our dental language we say, we tell the class 3 malocclusion, now is the class 1 malocclusion. Sorry, class 1 occlusion. And this is the aesthetic line after operation. It's another case of class 3 malocclusion after mandibular advancement setback and maxillary advancement. And this is the facial contour angle, aesthetic line. So, good planning and communication and free flow of information between the surgeon, orthodontist, and the patients facilitate the efficient and successful treatment and ensure orthognathic surgery is not a subject of fear today. Thank you all.